Welcome to the Myeloma Matters podcast, hosted by the Multiple Myeloma Research Foundation and focusing on topics related to improving outcomes for myeloma patients. This podcast is based on a roundtable discussion between Dr. Saad Usmani, Chief of Myeloma Service at Memorial Sloan Kettering Cancer Center, Dr. Joshua Richter, Associate Professor of Medicine, Tisch Cancer Center, Icahn School of Medicine at Mount Sinai, and Ashley Steinberger, a nurse practitioner at Memorial Sloan Kettering Cancer Center. This episode of Myeloma Matters reviews the latest data on bispecific antibody therapy for relapsed refractory multiple myeloma, as discussed at the 2024 American Society of Clinical Oncology and European Hematology Association annual meetings, including information about the use of fixed-duration dosing to mitigate adverse events.
Hello, I'm Dr. Saad Usmani, the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center. Welcome to this episode of Myeloma Matters entitled Bispecific Antibody Horizons, Dosing Strategies and Meeting Updates in Myeloma Care. Joining us today are my colleagues, Dr. Joshua Richter and Ashley Steinberger. I would welcome them to introduce themselves, starting with Dr. Richter.
Thank you so much for having me here today. My name is Josh Richter. I'm an associate professor of medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai, and excited to be talking about myeloma today.
Ashley?
Hi, my name is Ashley Steinberger. I'm a nurse practitioner at Memorial Sloan Kettering Cancer Center in New York City.
Wonderful. Thank you, Josh and Ashley, for joining. We'll start our discussion with, a couple of abstracts that were featured recently on Teclistamab. We'll start with the Majestic-1 updates, specifically focusing on the prophylactic use of tocilizumab and the incidence of CRS and severity. If you recall, Majestic-1 was the pivotal trial that led to the FDA approval of Teclistamab back in the fall of 2022. The original cohort of patients was a total of 165 that had not received prophylactic toci. Subsequently, there was a cohort of 24 patients that went on to receive prophylactic tocilizumab. This particular abstract that was presented at ASCO highlighted was the reduction in overall cytokine release syndrome with prophylactic toci, went from 72% of overall CRS down to 25%, and grade ones were around 50% in the original trial, went down to 8.3 in this toci prophylactic cohort. However, the grade 2 percentage was about the same, 16.7%. So, there were no disease characteristic differences between the groups, but, I found this, data, quite intriguing. They also presented on the responses in the two cohorts, and, the responses appear to be comparable compared to, the overall original patient population, 72 versus 63%. If you look at the follow-up time period between the cohorts, it was a little different. And so you do see some differences in the quality or depth of response. The median follow-up was only 8 months or so. And on the original cohort, the median follow-up is, reaching close to 3 years now. What are your thoughts about these findings? We can start with Josh maybe providing some comments, and then, I'll go to Ashley.
Sure. So, one of the things is that the three of us work in institutions where we treat dozens and dozens and dozens of myeloma patients per day and have whole teams set up to deal with things like cytokine release. One of the things that makes me very excited about this data is I think by bringing down the overall rates of CRS, there's a better chance of getting it in the hands of some of our community colleagues who may not be just like you, Dr. Usmani, who just came from seeing, 30 myeloma patients in your clinic with an amazing group of doctors and nurses and nurse practitioners. So to me, that's the biggest thing about it. Better pathway to outpatient dosing and community dosing.
All right, Ashley, what are your thoughts?
So I definitely agree. I think that it's going to bring down some of the barriers in starting the step up dosing. I think some patients are hesitant because of the admission to the hospital. So if we can somehow mitigate the cytokine release syndrome and make it safer for patients to get it as outpatient, then more patients would be more willing to proceed with the drug. I think it's also better for the hospitals as well and to not burden the floors with more admissions.
I'll ask both of you, have you started to use Teclistamab in the outpatient setting yet? Or if you're doing it, how are you picking patients for that? So, Josh, how are you guys thinking about this at Sinai?
We haven't quite delved into the full outpatient dosing just yet because I think a lot of the patients that we tend to give commercial teclistamab may be a little bit higher burden, so a little bit higher risk overall. We have what I like to call the early release program, which is we admit you to the hospital and almost everyone will get CRS within the first 1 or 2 step-up doses. And within 24 hours of that, we'll actually send them home because our internal data shows the likelihood of any severe CRS to occur after is extremely low. In fact, most people don't get any given the long half-life, and a handful will get only grade 1 CRS. So we send them home with some steroids just in case.
Ashley, what are your thoughts?
Yeah, we have done a few as outpatient actually, where they'll get the dose outpatient and then they go home with a vital signs monitoring machine that we can kind of closely monitor their vitals and be notified if any of the vitals are abnormal. So it makes it safer for them. But like Josh said, they have to fit a strict criteria and have a low burden of disease. And the people that go on this drug typically have a higher burden. So most of them are getting admitted, but some of them do fit the criteria to have as outpatient safely.
I know that, some of the Sinai colleagues have done this for CAR T cell therapies as well. And, we are doing the same for both, the bispecifics, and there's a CAR program. The other important abstract, was actually presented at EHA from our colleague at MSK, Carleen Tan. This was the MSK experience of less frequent dosing. So one of the concerns that has been raised by, around BCMA bispecifics is patients getting increased risk of infections, both bacterial, viral, and, or even opportunistic infections, with ongoing treatment with Teclistamab and other BCMA-directed bispecifics, requiring IVIG support for hypogammaglobulinemia, etc. So I think in this cohort of 86 patients who got at least one dose of Teclistamab, with a median of 6 prior lines of treatment, and a third of the patients had received a previous bispecific directed therapy as well. There were, a couple of different, groups of patients, the early initiators, which, were the patients that were treated in the first 4 months. And Josh, Ashley, you guys know how desperate we were for other options at that time. And, we all had long wait list for CAR T cells. And, we just let Teclistamab loose on that, area of unmet need patient population. Then we had, subsequent, patients where we had more experience with tech, and started to switch patients from Q week to Q2 week or Q4 week dosing. And what Carleen Tan demonstrated is that even after that switch that tended to happen around the 3-month mark, with subsequent follow-up of further 6 months, more than 90% of the patients actually maintain their initial responses. So our group had initially decided that since the median time to best response is within is about 3 cycles or so. In patients who are already demonstrating, responses of, VGPR or better, let's start dialing down the frequency of treatment. And, in our experience, it appears that patients continue to maintain responses. And I know that, Carleen will also be updating the infection data, but I thought the fact that, more than 90% of the patients actually have sustained responses was, pretty neat after that switch. So, Josh, what are your thoughts around this data? And, how has, the SINA experience been with the less frequent dosing? Is it any different?
I think one of the things that this data brings up is, we have to stop thinking about all of these drugs like we did classical chemotherapy. It's not all about dose intensity. It's not all about doses higher, dosing lower. It's about getting your immune system to do what you need it to do, and then trying to find that Goldilocks zone between forcing every T cell to wake up and fight cancer, and then taking every T cell away from fighting infection. So I think your description of the landscape is perfect. When these first came out, we were desperate to get these drugs into the hands of our patients, and now we have taken a very similar path, just as you guys have, which is kind of quickly getting to less frequent doses. I think a lot of us try to follow the daratumumab like schedule, 2 months of weekly, 4 months of every other week, and then monthly. But there are patients that are in CR or better within a few cycles. For some of those, we feel absolutely fine going right pretty quickly to monthly dosing.
Ashley, what are your thoughts? Because, you actually take care of a lot of these patients.
Yeah, so I have similar experiences. So definitely patients are tolerating the drugs better when they are given a little bit less frequent and they are getting less sick and the immunoglobulins come up a little bit better. So it just seems like, and they seem to continue with a good response. So we have a patient that sometimes will go travel for 3 months and come back and still have undetectable disease. So it seems to be that some of them get very deep, durable responses.
No, thank you. And just staying on that theme here, with these amazing results with BCMA bispecifics in the relapse state, it was only a matter of time, that we started to think about combining them with other therapies in earlier lines of treatment. And we actually got the first glimpse of the Majestic 7 safety cohort. Josh, I would love your comments on this frontline treatment regimen. What was the regimen, and what were the data?
So I think it's been an exciting, you know, about 6 months or so. We've seen, many years of everyone focusing on the relapse space. And then within the last 6 months, between seeing transplant eligible studies like ESA KRD, transplant ineligible like ESA VRD, and now with Majestic 7 giving Teclistamab, Darzalex, and lenalidomide, I think we've really seen this kind of push to, get these unbelievably deep responses up front, maybe so deep that we don't even need to get to the relapse setting. So Majestic 7 was a multi-arm study, but what they really put forward data-wise was the Teclistamab, Darzalex, lenalidomide cohort, and median follow-up now of almost 14 months. And the data is, not unexpected from a safety standpoint. About two-thirds of patients are going to have CRS. Most of this occurs in cycle one. Icons is very rare. I think they only had one case that was a grade one. Most of these patients are able to maintain good dose intensity. Really, the big side effects besides heme toxicity and lowered blood counts is infections. I think we saw a fair amount of infectious complications in this, and not unexpected when you start to mix CD38 and BCMA. And I think what Ashley alluded to before was perfect, is that, with BCMA therapies, we have to be concerned about hypogamma and the infection. And when you mix Darzalex in it, it can make it a little more profound. But I think one of the things that we really liked was the efficacy of this regimen. And ultimately, the overall response rate was 92.3%, with more than 92% of patients having a VGPR or better. So, a highly effective regimen, and so far, no one has progressed. So, I think T cell redirection with the recent approval on first relapse established the dominance there, and now we're starting to see some great data in frontline.
Ashley, what do you think about these data? And one thing that I do want to highlight, with this regimen, I think the teclistamab dosing follows that of daratumumab, Josh. So I think you go from weekly to every other week to monthly dosing, and that's the piece that I also liked about how this cohort was run and designed, because that will help mitigate that infection risk, issue. Ashley, what do you think?
This is really interesting, and it could change a lot of what we do as upfront treatments for multiple myeloma if the response rate is this high. And I think we're learning more about how to kind of combat infections and prevent them.
And this was, interestingly, so Majestic 7, is like a multi-cohort phase 1 to figure out safety, and then there's a randomized trial. And this regimen is being developed for the transplant ineligible or older patients. So, and it's going to challenge Maya, so DRD. I'm really looking forward to the phase 3 portion of this trial opening and for us all to enroll patients on it because, the depth of response we're seeing is, amazing. And the fact that, Maya has already, made such a big impact for that older myeloma patient population, seeing a regimen that can even supersede that is, I'm really looking forward to that. So, I'd be curious to see how this plays out and, what that, final clinical trial design looks like. Let's turn our attention to data on other BCMA-directed bispecifics. Dr. Moti presented updated efficacy and safety results from the Magnetism 3 trial that has now had more than 2 years of follow-up after the last patient was originally dosed. So this is long-term survivorship from that original clinical trial. A total of 123 BCMA treatment-naive patients with relapsed refractory disease were treated with Elranatamab. A third of those patients had extramedullary disease, 15% had high-risk karyotypic abnormalities. And the median prior lines of treatment was 5. Triple-class refractory made up vast majority of patients, almost 97% of this patient population. Overall response rate was very similar to what had been reported with Teclistamab. It was around 61%. But MRD negativity was 90.3% in the evaluable patients who had complete responses or better. And the complete responses or better were there in around 38 or 39% of the patients, if I remember correctly. The median PFS was quite impressive at 17.2 months, and median OS for this population was over 2 years. And just for context, for this triple class refractory patient population, the median OS we would expect is only 8 to 9 months. So, amazing results. And I don't think that they reported any new safety signals from an infection risk or long-term follow-up perspective. Josh, what are your thoughts about the ELRA long-term follow-up?
So I think this confirms the data we've seen all along. With some of the great data presented by Dr. Lusokin at your center. So we've seen a lot of this great data. It's nice to see the follow-up. It's really nice to see no increase in second primary malignancies because we've seen that unfortunately with the Carvykti product. Head to head between this and Teclistamab, hard to say a lot, although the nice features are that it's a shorter step-up dose and fixed dosing as opposed to weight-based. But again, another great asset to have in our tool belt.
Ashley, what do you think? We've had experience at our site with ELRA, during the clinical trial phase and now, with the commercial product.
So I think that, this is, again, what Josh said just confirms that people do get deep and durable responses to these bispecifics. And this is in BCMA naive patients. So I would be interested to kind of learn more about the patients that have had BCMA and had ELRA and if they did respond, because with tech, I think that you still could respond even if you had prior BCMA.
And I'm going to now turn to Josh to review data on other BCMA-directed bispecifics.
Let's take a look at what's on the horizon for treating relapsed and refractory myeloma. So, Assad, as you already pointed out, we already have 2 FDA-approved BCMA targeting bispecifics, Teclistamab and Elranatamab. But there's some good data coming down the pipe on a couple others, including Linvoseltamab and ABBV-383. And we recently saw some data presented by Dr. Lynch over at Columbia from some of the updated phase 1/2 results of the linker MM1 study. So at a median follow-up of around 14.3 months, we saw very high efficacy. And again, it's, in myeloma, you're never supposed to compare trial to trial. So you have to say that statement, then you take a deep sigh. and then you go on to compare trial to trial. So shouldn't do trial to trial comparisons. Ah. So we see an overall response rate here of 71%, which is so far the highest in class, but again, there are noticeable differences between the different trials. So it is a quite high number, but the others being around 63, 64% are also in the same ballpark. We saw a CR rate of 50%. Median duration of response was almost 30 months, and progression-free survival was not yet reached. 70% of patients were still in remission at the 12-month mark, median OS of 31 months. So very efficacious drug. In terms of the safety profile, again, like with all the bispecifics, the big treatment emergent adverse events are things like CRS and ICONS. Overall, the CRS rates were relatively low, and the majority of this, like the other assets, grade 1 and grade 2. And I think that in terms of efficacy and safety, Teclistamab, Elranatamab, Linvoseltamab are all very, very similar. Maybe one drug is slightly higher in this parameter, one is slightly low in that parameter, but I think the three are all great drugs. And we're really waiting for the linker MM3 study comparing against ELO-POM as the registration phase 3 for future data. The next abstract drug we're going to discuss is the ABBV-383 bispecific antibody. This was presented by Dr. Wiesel, and this was another large trial, 220 BCMA naive patients with a median number of lines of 5. And I think exactly as Ashley pointed out, we know this great data in a BCMA naive population. We really need more data about evaluating these drugs in patients who've had other BCMA assets like CAR T therapy. So one of the really nice things about the ABBV-383 drug is that it goes right away to monthly dosing. So I think that's a really nice feature of the drug, a really great quality of life thing for patients, because the other drugs will stay weekly and or go to every other week. We do have data for extending out Teclistamab and Elranatamab to monthly. Linvoseltamab actually has built in, when you get to week 24, if you're in a VGPR or better, you go to monthly dosing. But here with the 383 compound, you go right away to monthly dosing, well within parameters. So in terms of CRS, overall, very well in line with some of the previous assets. When we looked at the 40 milligram and 60 milligram doses given every 3 weeks, we saw CRS rates of 71 and 70% respectively, but at the Q4 week dosing, it goes all the way down to 43%. So a really well-tolerated drug overall. So when we talk about the overall response rate, looking at the different dosing strategies, this is very much in line with the other bispecifics. And with the 60 milligram Q4 week dosing, we see an overall response rate of 65%, with more than half of the patients achieving a VGPR or better. And a little bit of a shorter follow-up with this cohort, but overall responding very quickly. First median time to first response of around a month. So again, overall, I think we can find little parameters here and there that may be subtly different between the different BCMA assets, but they're all pretty much in line safety and efficacy-wise.
So the key takeaways from the BCMA-directed bispecific data, it looks like prophylactic tocilizumab may be able to help mitigate frequency of CRS with teclistamab. The Elranatamab, I don't see any reason why we won't be able to utilize the same approach for that FDA-approved BCMA-directed bispecific. I think the real-world data shows that less frequent dosing is doable and does not impact the durability of response, at least at the 6-month mark after the change. And then combining bispecifics with standard myeloma treatment looks promising. In the depth of response we're seeing in those early cohorts in Majestic 7 look great. And then early phase trials of investigational BCMA-directed antibodies look promising. The Linvo data, again, the CRS pattern from that experience appears to be the most impressive out of the lot. But then we have ABBV-383, which is the monthly dosing convenience. So a lot going on in that space, and we're moving to phase 3 trials with these bispecifics. Josh and Ashley, would you like to add any other key takeaways?
So I think that, what these trials are showing is that these drugs work very well. And I think in the real world, that is what we're seeing. We're seeing people respond quickly and have long responses. I think also these abstracts are pointing to kind of trying to make this safer for patients, easier for patients, and easier for healthcare providers. So all good things in the pipeline.
So let's move on and review recent abstracts on non-BCMA-directed bispecific antibodies that were presented at ASCO and EHA. Dr. Leo Rasche shared long-term efficacy and safety results from the phase 1/2 Monumental 1 study of Teclistamab in relapsed refractory multiple myeloma. As you all know, Teclistamab is a GPRC5D-directed bispecific antibody that was approved by the FDA based on the Monumental 1 clinical trial. The approval came about a year ago, and it was based off of the two cohorts of patients who received the 0.4 milligram per kilogram weekly dose of Teclistamab. And then there was a second cohort of 0.8 milligram per kilogram of Teclistamab given every 2 weeks. The median PFS reported with the 0.4 milligram cohort was 7.5 months, and it was around 11 months with the 0.8 Q2-week dosing. In patients who had triple-class refractory disease, the median progression-free survival was about a little less than 8 months. The overall responses were quite impressive. They were in the 60 to 70 odd % range. I'm going to call out the most significant one or more the relevant, in terms of the population that we treat, almost 67% for the triple class refractory population. And each of the cohorts had almost 55 to 60% of the patients achieving a VGPR or better. So really impressive depth of response. From an AE standpoint, I don't think CRS was as significant an issue as were some GPRC5D associated AEs. So, I want to actually go to Ashley and just, get your thoughts on the GPRC5D specific side effects that we see in clinic. Can you share, the Teclistamab experience on the clinical trial data as well as your own?
People are responding well to this drug, but they have a hard time staying on it because of the side effects. So you really have to be upfront with them at the beginning when they're going on it and tell them what to expect. Personally, what I see the most in clinic is the taste changes and people losing a lot of weight. So usually when we hold a dose or spread out the dosing, the patients kind of can tolerate it better. There also can get nail changes and skin changes. So the skin changes can be peeling on the hands and feet, which will be presented a little bit later. And then also the nails can kind of separate from the nail bed. There can be nail pitting. And also generalized rash, which I haven't seen as much, but the skin and nail changes and taste are very common with this drug.
So, Josh, are there any other safety issues you want to highlight from the Monumental 1 study or with Teclistamab?
No, I think overall Ashley did a great job. I think her assessment of this is really accurate. Is that it's not the easiest drug to keep people on. So the way I think about it is, some drugs in myeloma are an ends to a mean, and some drugs are a means to an end. And right now, a lot of the patients that we use talquetamab is a means to an end to get them to a CAR T, to get them to the next type of therapy.
Yeah, and speaking of safety profiles, there is, data relevant to infectious complications of bispecifics and CAR T cell therapies. Ashley, do you want to comment on some of that new data?
Yeah, so as we've mentioned multiple times, infections are kind of one of the biggest things with CAR T cells and bispecifics. So there was a retrospective analysis that Julia Mercy and colleagues evaluated infectious complications of any grade in 137 patients treated with either BCMA or GPRC5D directed bispecific antibodies or CAR T cell therapy. So of these 137 patients, 58 were CAR T, 47 were BCMA targeted bispecific, and 32 received GPRC5D targeted antibody. Kind of what they saw was that there were less infections in the patients that received the GPRC5D versus the BCMA antibodies. So the rates were 76% for CAR T therapy, 85% for BCMA, and 59% for GPRC5D targeting bispecific antibodies. So most of the infections were of the respiratory tract viral infections. So, while the talquetamab can cause a lot of other side effects that are unwanted, like the nail changes, the taste, etc., one thing it does do is it doesn't put you as high of a risk as some of the other bispecifics. Now we're going to transition over to Cevostamab, and Josh is going to cover that.
Sure. So we saw the KAMA-2 data presented at EHA by Shaji Kumar. The KAMA-2 data was specifically looking at Cevostamab, which is an FcRH5 CD3 bispecific. But the KAMA-2 data was only looking at patients who had had prior BCMA therapy. So what we saw is early data, a small number of patients, no real post bispecifics in this cohort. It was really either patients receiving ADC with belantamab mafodotin or prior CAR T therapy. And overall, the drug is well tolerated. Similar toxicity profile to the other bispecifics. So it doesn't have the nail, skin, and dysgeusia that we see with talquetamab, but it does cause CRS and ICONS at similar rates to the other assets. In terms of infection, if I had to rank them, I think BCMA causes the most infection, GPRC5D the least, and Cevostamab is probably somewhere in between. But overall, a fairly well-tolerated drug. In terms of efficacy, for the entire cohort, we saw an overall response rate of 67%, but this was higher in patients who had had prior CAR T rather than the ADC. So it was 73% in prior CAR T, 60% in prior ADC. And this is really in line with what we're seeing when you even go from BCMA to BCMA asset, that the longer the distance in between that attack, the better you do. And when you're on an ADC, you're on it more regularly. So the time in between dosing between the ADC and Cevostamab was shorter, and that probably impacted the response rate. But overall, response rates were quite high, with about 20% of patients getting VGPR or better. And again, 73% response rate post-CAR T is a really exciting thing, especially as CAR Ts are moving earlier and earlier on, that we have some great therapies as salvage when we need them. Saad, your thoughts on key takeaway points?
Yeah, I think the long-term efficacy and safety of talquetamab is confirmed based on the longer follow-up that was presented. The points that both you and Ashley made about the infectious complications with bispecifics, where BCMA bispecifics rank higher than GPRC5D, and Cevostamab is somewhere in between. And the CAR T-related infections with BCMA CARs is actually lower than what we see with the bispecific. So I think it's important to appreciate that. And, the early data with Cevostamab is in cohorts of patients with prior, bispecific and CAR exposure. So, I look forward to seeing a little bit more of that data in those cohorts with longer follow-up, because, relapse disease beyond these therapies still remain an area of unmet need. And we have many of those patients in our respective clinics. In the previous sections, we discussed key clinical trial data that was presented at ASCO and EHA. Let's try to see if we can talk about a patient scenario and illustrate how to optimize the use of BCMA-directed bispecific therapy in clinical practice. And, we're going to have robust discussions with my two esteemed colleagues. So we have a 72-year-old woman with high-risk multiple myeloma. Performance status is 2. At the most recent progression, the patient has amplification of 1q21 along with deletion 17p. In terms of treatment history, the patient started with DRD as initial treatment like the Maya trial, but then daratumumab was discontinued and Len maintenance was continued. VGPR was the best response, but the patient progressed after a year and a half. Then they received a dose-attenuated regimen of bortezomib, selinexor, and dexamethasone, which resulted in a duration of response of about a year, PR as best response. Then the patient went back to daratumumab with pomalidomide and dexamethasone for another 9 months or so before progressing. And the last line of treatment was a dose-attenuated carfilzomib with cyclophosphamide and dexamethasone, but they only got it for about 5 months before, showing clinical progression. What would be the considerations of treatment for this patient? This is a transplant ineligible patient, likely being considered for a BCMA-directed bispecific therapy here. And I'm going to turn to, Ashley and Josh. Ashley, do you agree, this fourth line treatment patient who's had, all the drugs, but, in different doses and schedules, probably because of their performance status and not being, transplant eligible. But, what are your thoughts? What are the options for this patient? And would you consider a BCMA-directed bispecific?
I think we would because the performance status is still 2. It's not terrible. So I think we would. We would just need to be careful about giving them maybe not weekly treatment, maybe every other week. I'm not sure, selecting between Elranatamab and Teclistamab. Elranatamab maybe has a shorter hospital stay. I'm not sure if that would be a better option. What do you guys think?
So, Josh, I'm going to ask you, would you treat this kind of patient in the outpatient setting, or you'll start inpatient and then transition outpatient?
I think the devil's in the details. I mean, I think if the PET scan showed, a whole bunch of lesions that was really bulky, I would treat the patient inpatient. But if this is simply a serologic relapse, which is likely going to be, I think that we certainly could treat them as an outpatient. Again, depends upon comorbidities and how much they can tolerate and access to a center that could treat CRS if it popped up, but definitely reasonable.
Okay, and then Ashley brought up, whether to dose them less frequently from the get-go or start weekly and then go less frequent. How would you do it?
So I actually kind of approach all BCMA therapy, also belantamab, the same way, which is those initial doses I give kind of on schedule. And once we get the response we need, then we back off. So I would start off with the weekly dosing, and the reason to make sure to kind of keep that for a little bit is the prior therapies really hasn't had a deep response, never got those CR, MRD negative responses. So I would really try to eke out a CR or better here, if possible, before switching to less frequent dosing.
All right. And then, when trying to modify dosing, Ashley, what would be your biggest, concern? Suppose the patient is responding. What would be your thoughts around, the less frequent dosing?
So less risk for neutropenia and infection would be the reason to back off eventually once they have a good response.
And, what's the current dosing schedule for Elra at the moment?
So this is a typical dosing schedule where it's given on day 1, 4, and 8. So the step up dose on day 1 is 12 milligrams, and then step up dose on day 4 is 32 milligrams. And at MSK, they will be discharged, I believe, at this point. And they come back for the first treatment dose on day 8 as outpatient, and that's 76 milligrams. And then after that, it's given weekly up until week 25, where we switch to every other week.
So we have become comfortable in dosing patients now on days 1, 3, and then 5, just like, we did for tech as well, so that we can transition patients out, sooner than later. But we do that, on a case-to-case basis as well. Josh, are you guys trying to do that as well?
Yeah, doses on day 1 and 3, and then 48 hours later, discharge on day 5. And yeah, I think assuming the patient is stable without active CRS, I think we're all kind of taking that approach.
Instead of Elra, we picked Teclistamab. What are your thoughts around the dosing and the step-up period? Ashley, what are the differences, and are they going to be any different or about the same?
So they are similar. So the dosing is about day 1, 4, and 7 as well, except the patient is in the hospital the entire time and for 48 hours after the 7th dose. So day 1 would be the dose. It's dosed by weight, so 0.06 milligrams per kilogram, and then day 4. The second dose is 0.3 milligrams per kilogram. And then the first treatment dose is given on day 7, and it's 1.5 milligrams per kilogram. That continues as weekly, as outpatient after that. So after day 7, they keep them in the hospital for about 48 hours to monitor for CRS. And if no CRS and they're stable, they discharge 48 hours after day 7. Also, it's been updated that patients who have maintained a CR or better after 6 months, that we will reduce dosing to 1.5 milligrams per kilogram every 2 weeks. So this is the standard dosing, but also step-up doses can be administered between 2 to 4 days after the previous dose, given that the patient is stable, and maybe given up to 7 days after the previous dose to allow for resolution of any adverse reactions.
Josh, what has been your clinical experience with CRS and ICANS in patients who are receiving bispecific antibodies?
So as far as CRS, it seems that most people get it. The majority is grade 1 and grade 2, and I think a lot of this has to do with your tocilizumab approach. At Sinai, the minute you spike a fever with grade 1, we pounce on you with toci. I've spoken to other myeloma experts who have used the phrase, we let them sizzle a little bit. I'm not a fan of letting people sizzle. And then once they get toci, they tend not to have anything else in terms of CRS after. Icons, though, even though the rates are very low in the clinical trials, I have to be honest, it's been a little bit higher in clinical practice, and I think this is related to an overall higher burden disease, sicker patient that we're treating with standard of care bispecifics than what was done in some of the clinical trials. But still, overall, grade 1, grade 2, most of this is managed across the board, tocilizumab and/or steroids for CRS. For icons, usually steroids and occasionally needing to use anakinra. I think if we look at, the trial data, we'll see that, CRS was, the majority of patients, but, almost no grade 3 or 4 CRS and really no grade 3 or 4 icons.
So, Ashley, assume patient starts the treatment with Elra. What principles should inform infection prevention?
So these kind of remain the same as far as I know with Teclistamab and Elranatamab. So there are a lot of things that we do kind of to mitigate infections and decrease the risk. So first is just education for the patient and letting them know that they will be at a higher risk for infection. So tell them, be more careful in certain situations in crowded areas, wash their hands frequently, things like that. So just kind of neutropenic precautions. We also, if they are neutropenic, give growth factor like Neupogen or Neulasta to help combat that. We will give PJP pneumonia prophylaxis. So whether it's Bactrim or Atovaquone or pentamidine, they'll receive one of those to make sure they don't develop PJP. We also will give them acyclovir to prevent shingles reactivation. We monitor hepatitis B as well. And if they have a positive core antibody, we will likely give entecavir to prevent reactivation of hepatitis B. Also, we monitor CMV levels to make sure there's no activation of CMV. And lastly, most patients on teclistamab or elranatamab will have to go on IVIG and have close monitoring of IgG levels.
So to summarize the key points from this section, bispecific antibodies as monotherapies are efficacious in relapsed refractory multiple myeloma. we are seeing early, deep, and durable responses. And these therapies are off the shelf. So, whether it's a clinical or biochemical relapse, they're easily accessible for us to utilize in our clinical practices. Overall management strategies, that may help mitigate CRS and ICANS are important. So early recognition is the key. Tends to happen, during the step-up dosing or the first dose of treatment. But what's encouraging is that unlike CAR T cell therapies, most of the events are grade 1 or 2. And ICANS, seldom happens with, any of these products. So vigilant monitoring, prophylaxis, and treatment can prevent infections. And, Ashley rightly highlighted the VZV and PGP prophylaxis strategies. And for patients, who may require, entecavir for Hep B core antigen positivity. These antiviral and antimicrobial strategies need to be continued throughout the treatment. And for patients developing hypogammaglobulinemia, IVIG replacement is strongly, encouraged for all patients. Let's move on and discuss how to optimize the use of GPRC5D-directed antibodies. So let's take, essentially a similar kind of a case. So we have a patient who is 74 years. They have a good performance status with an ECOG of 1. So in terms of treatment history, patient got VRD as induction, then transplant, and then Len maintenance. And then 3.5 years later, the disease was relapsing. So they were switched over to daratumumab with pomalidomide and dexamethasone, remained in a duration of response of about 18 months or so. VGPR was the best response, even with this line of treatment. Then patients went on to have another relapse and receive carfilzomib with cyclophosphamide and dexamethasone as their next line of treatment before progressing a year later and then being placed on selinexor and dexamethasone for about 4 months before progressing and then received a BCMA-directed CAR T cell therapy. They remained in a response for about a year before progressing, and they're now being considered for GPRC5D-directed bispecific antibody treatment with talquetamab. So Josh and Ashley, assuming the patient starts talquetamab, what are the unique side effects that we would need to discuss with the patient? Josh, maybe we can start with you first.
Sure. So, anytime we're talking about any targeted antibody-based therapy, the question is always, where else is that target expressed other than the malignant plasma cells? And for GPRC5D, we know besides plasma cells, it's expressed on the squamous epithelium of the hands and feet. So dermatologic side effects are something we note. The desquamating rash that people can get actually reminds me of Xeloda, back when we used to use more Xeloda, back in fellowship for me. And then some nail related issues where the nails can become brittle, even fall off, or become discolored and have ridging. The other thing is that GPRC5D is expressed in the oropharynx and salivary glands, and dysgeusia, weight loss, anorexia. These are really the big issues that we see. I think there's a lot of work ongoing to figure out the optimal mitigation strategies. Right now, it's, working with the nutritionist, small frequent meals, making sure that things like artificial saliva to help with making sure the dry mouth is not an issue. And then there's a lot of kind of ad hoc experimentation with things like, lemon and sour or MSG or oral dexamethasone washes. I would love to know, Ashley, if you have any tips and tricks that have worked particularly well for you with your patients.
So for the skin-related changes, we see a lot of, as Josh said, peeling of the hands and the feet. So they do suggest that the patients can use ammonium lactate 12% cream twice a day. And then also patients can have more of a generalized rash. And if there's itching, they might need to apply some triamcinolone. Also, just adding in any thicker based ointments like Eucerin or Vaseline can help hydrate the skin. And oral antihistamines, of course, can be used if there's any generalized itching as well. With nail related changes, as we stated prior, they can fall off, they can become very brittle, they can have nail pitting or separation from the nail bed. And this usually can start around cycle 2 and last, from what I see, for most of the time that they're on the medication. They should avoid long, frequent durations of water immersion, and can also apply Vaseline or Aquaphor, vitamin E oil, nail hardeners, and then biotin can also help with a nail growth and hardening, and then also just filing the nail edges to be more smooth. And then another side effect that they can get is dysgeusia and xerostomia. So dysgeusia is the change in taste that people can have, and this is a little bit difficult to combat. So usually dose modifications in the drug, reductions or delays or skipping a dose can help with the management of this. And then just telling patients to have things high in calorie and small frequent meals. So also you need to monitor nutritional, like vitamins, make sure they're not becoming iron deficient, B12 deficient, folate deficiency. And then xerostomia is dry mouth, which is also can be seen increasing hydration and having water throughout the day to keep the mouth more moist, and then also using topical agents like saliva sprays or sugar-free chewing gum or candies to help stimulate saliva flow. And then lastly, they can use sodium lauryl sulfate-free toothpaste, which might be better tolerated than the other toothpaste. But like Josh said, referring to the dietitian or nutritionist early is encouraged. And then we're also going to go over the dosing of talquetamab. Similar to the other medications, there's a standard dosing, but it can be given a little bit earlier if there's no adverse reaction. So the standard would be giving it on day 1, and it's body weight based. So it's 0.01 milligrams per kilogram on day 1. Day 4, 0.06 milligrams per kilogram. Day 7, it's 0.4 milligrams per kilogram, and then given weekly thereafter. You would not want to give it earlier than 6 days after the full dose, the first treatment dose. And then can also have a biweekly or every 2 weeks schedule. So similar to the weekly in the beginning, it's 0.01 milligrams per kilogram on day 1, 0.06 milligram per kilogram on day 4, and then 0.4 milligrams per kilogram on day 7. And then the first treatment dose is 0.8 milligrams per kilogram on day 10. And then it's given biweekly as 0.8 milligrams per kilogram. And in this one, you would want to maintain a minimum of at least 12 days between the biweekly dosing. But the doses can be administered between 2 to 4 days after the previous dose, if there is no CRS or adverse reactions.
So the key takeaways from this section, it's very important to educate the patient to be their own advocate. The best prepared patients as they're starting to use new therapies are going to help mitigate and manage these side effects. They need to know what to look for and how to best reach the healthcare team. Preparing patients for possibility of off-tumor on-target effects of talquetamab is very important. So, again, repetition is going to be the key here. And patients who know these are common are usually able to cope much better because they can anticipate, what is coming down the pike. Ashley, any other thoughts to what I've shared?
Yeah, that's pretty much it. If they kind of know what to expect, they're kind of able to reach out and ask for help more easily.
Any other pearls of wisdom, Josh?
The only pearls of wisdom I would say is just ongoing communication with your healthcare team. I think, we have some tools to help mitigate a lot of the side effects of the bispecific antibodies, and you don't get extra points for suffering. So reaching out, because as a myeloma community, even though these drugs are new, we're all sharing at even events like this, where we share our little tips and tricks about how to make the treatment better for everyone. So open lines of communication always.
Absolutely, Josh. I think, that's the key, especially in this late relapse setting where our patients may think, oh, I'm benefiting from this treatment. Maybe I shouldn't tell that, this is something happening. I might be taken off of treatment. No, that's not the goal. The goal here is to find the right recipe, the schedule, and then help manage your, side effects as they come along. And the sooner we know about them, the more time we have to actually come up with a game plan with you. So this concludes our discussion entitled Bispecific Antibody Horizons, Dosing Strategies and Meeting Updates in Multiple Myeloma Care. Thank you for joining us. Please make sure to complete the evaluation. This information will help guide the development of future educational activities and resources.
Thank you for listening to this episode of Myeloma Matters on the latest data on bispecific antibody therapy, hosted by the Multiple Myeloma Research Foundation. We would like to thank Dr. Saad Usmani, Dr. Joshua Richter, and Ashley Steinberger for sharing their expert insights on bispecific therapy for myeloma treatment. The Multiple Myeloma Research Foundation also thanks Johnson & Johnson and Pfizer Incorporated for their support of this educational podcast. If you have questions about anything you have heard today, please call the Multiple Myeloma Research Foundation Patient Navigation Center at 1-888-841-6673 for more information.